Thank you, Misha. Okay, so we were on this slide, and I don't know if we reviewed sort of what it's like and what our thoughts are when we see these older patients in our emergency room. Next slide. Okay. So essentially, when we think about why older adults come to the emergency room and why it's not necessarily the ideal place for our older patients, you're absolutely right. It's crowded, it's confusing, it's disorienting, and it's chaotic. But what we're seeing is that older adults are more frequently presenting to the emergency room, and not just for an acute injury or trauma, but often an exacerbation of their chronic medical issues, or certainly now living with chronic geriatric syndromes and they're no longer safe in the community. In 2010, in the Annals of Emergency Medicine, they've outlined sort of the main reasons why older patients come to the emergency room. Great, and it's not so surprising that falls, the very common Geri syndrome, is probably the most common reason why an older adult is coming. You know, the second most common presentation of cardiac illness, right? Which only makes sense in the sense that as you get older, the risk of cardiovascular diseases and complications certainly become more common. And I highlighted something on the bottom here, abdominal pain, which in many cases is actually extremely difficult and distressing, even for the most competent and astute emergency physician, clinician, or surgeon, right? Just because older patients are somewhat atypical in how they're presenting. So we're going to walk through a couple of cases, but I just wanted to highlight and certainly some of the spectrum of diseases that we'll see in presentations. And also noting that while falls, I mentioned, is the most common, and it can be anything from a mechanical fall and trip with mild injury. It's essentially the presentation of anything here listed, be it a new infection, a new neurological event, a cardiac event, or an adverse drug reaction. Next slide. So some of the characteristics that you'll often hear about are, one, this atypical clinical presentation of illness, and I'll talk a little bit more about that. I know at Morningside and West, you guys are part of the age-friendly health system, so I'm certainly aware of the 4M model, right? So the fact that there's a higher prevalence of cognitive impairment with older patients, the multiple comorbidities that they're living with, and polypharmacy, older adults tend to have increased frailty, increased disease severity, delayed diagnosis, and certainly their presentations are often associated with worse outcomes. Next slide. And when we talk about atypical presentation of illness, I know you'll be having a discussion on hazards of hospitalization, but I think you'll hear us geriatricians refer to this often, but also it's important to recognize that that is often the most typical presentation of illness for older adults. And what we mean by that is anything from the vague presentation of illness, the altered presentation of illness, or even just the non-presentation of what you've been taught throughout medical school and your early training of what's normal in terms of classic disease presentations. So for an older adult, this could mean anything from that acute confusion, a new fall, just generalized failure to thrive, not eating, not walking, new incontinence is enough to say that the patient is probably not at their baseline and something is off. And while there's no clear understanding as to why, there's a multitude of factors. One is the susceptibility as you age to illness, so that's part of that normal physiological processes. The pathophysiological changes of aging, which is essentially thinking of it as the accumulation of your comorbid illnesses, that as you live longer with all these chronic illnesses, your body struggles to overcome them, and they become more clinically symptomatic or more clinically difficult to manage. And you combine that with this concept of frailty, right? That geriatric syndrome, which really just identifies that these patients are in this increased vulnerability to these stressors and difficult to overcome. Next slide. So with all of that said, is just a brief introduction to some of the cases we'll go through. But I wanted you to appreciate, you as clinicians and frontline providers, that whenever you're meeting or seeing these older patients that you're admitting through the emergency room, this is a sentinel event. They do take more time. They do present atypically. And unfortunately, every hospitalization or ED visit is associated with the greater risk of complications, functional decline, and what they've described as poor health-related quality of life. Older adults are 2.5 to 5 times more likely to be admitted after that ED visit, 5 times more likely to require ICU evaluation for same presenting symptoms. And even for those patients that we discharge acutely, nearly a third return within a 30-day period. So really thinking about every time we're meeting these older adults in the acute care setting, this is a sentinel event in their healthcare trajectory. So let's switch gears and we'll move on to the next slide and review a few cases, and I'll walk you through them, and most of them are based on true stories. So and I'll add some teaching pearls that I think are important for new doctors. Okay, so next slide. So our first case, imagine that you are the resident on call and you're admitting a patient who's coming from a nursing home with a fall. All right. So just a couple of things that I think is important to recognize, that when an older adult comes from a facility, they're not all coming from nursing homes, right? So there's a difference between a long-term care versus a subacute versus an independent living facility. And I say that just because I think it's important to appreciate that older adults represent a heterogeneous population. So whether or not a patient is in a nursing home, that's where they live. Subacute, meaning that they are still recovering from whatever acute illness, but yet are in a short-term stay for a facility, versus an independent living facility, right? These are very independent older adults. And just so you get a sense of who they are, where they're coming from the community before they got sick. But our patient here is coming from a nursing home. So your local nursing home, next slide. And as we know, and there's been a lot of efforts now as well in the care that's provided in a nursing home, there is some medical oversight in terms of physicians and nursing and pharmacists that are managing these patients, and we're caring for patients, as you can imagine, the ones you're sending to subacute rehab after an acute hospitalization, who are still sort of recovering and very sick, so extremely highly vulnerable patient population. So when a patient is coming from a nursing home to the hospital, these facilities are also highly regulated on why they're sending, and a good reason to send these patients. So these patients tend to be typically sick, and there's a good reason. And and some of them may have actually started some treatments in the nursing home. So it's good to understand what has been done in terms of IV fluids and IV antibiotics. But essentially, when a patient is coming from a nursing home, the good reasons that they're being sent over is something acute is happening, whether or not it's acute chest pain, shortness of breath, altered mental status, acute abdominal pain, limb threat, thinking about sepsis that hasn't responded to their treatment already at the facility, or have they had blood work and labs that were done that are now concerning, that are life-threatening. The not so good reasons are on the right side, and hopefully that is not what's happening. A patient who is potentially has chronic illnesses and it's an exacerbation that they just haven't managed for several days, or fecal disimpaction, they need a fecal disimpaction, or a PEG, right? It's Friday night, and rather than waiting through the weekend, a patient is sent. But it's really important that a lot of these patients are coming in with a lot of information that's valuable. So I'm going to walk you through the next one. So you're going to look at what's provided. Next slide, Misha. In that paperwork. In our institution, it's often scanned in the ED media form, but you want to look at what information is coming with that patient, especially if they can't tell you the story themselves. So there's typically a contact for the provider, the demographics, what their advanced care planning wishes are. So you want to look for something called the MOLST form, a medical order for life-sustaining treatment, or what their documented code status or conversations in healthcare proxy, or next of kin, if anything. Their current med lists, current labs, right, if they were done at the nursing home, and what medications were tried. Had they been on antibiotics for several days before they were actually brought in? I mean, a little bit about prior hospitalizations. A little bit more detail about their medical history. Is this an older adult who's had surgery before, has prosthesis, has devices that we need to be aware of? And to me, what I think is the most important is also what their baseline cognitive and functional status is. And that is truly important. I know it gets lost in transfer paperwork, but really take the time to understand who your patient is. Next slide. So we're meeting our patient. He's 77. He's transferred. And the reason for his transfer was that he has increased confusion that, that occurred after a fall about 2 days ago. It was not witnessed. There was no loss of consciousness. And what we know is that our patient is wheelchair bound at baseline. Next slide. On exam, I have his vitals listed here. He's hypotensive, 80/60, slightly tachycardic at 110 and tachypnic at 28. He has a fever of 102, finger stick is 160 and satting 94% on 2 liters of oxygen. He doesn't look well. He looks disoriented, pulling at the sheets. He's dry, mucous membranes, dry eyes. He's got bilateral rails and a 2 out of 6 murmur. Unclear if this is a new murmur. His abdomen is soft, non-distended, and slightly tender. They did a rectal and his guaiac was negative. You can advance the cursor. And neurologically, he's ANO times 0. He's groaning to pain and he's moving 3 out of the 4 extremities. Next. This is him lying in the stretcher, and you can pay attention to his lower extremity, where his left lower extremity is slightly shortened, hard to tell in this picture, and externally rotated. Okay. So what's going on with our patient? Oh, go back. What do you can unmute yourselves or put in the text box. What are you worried about? Just looking at the vitals in your exam. Sepsis, great. Sepsis, hip fracture, shock. Excellent, great. So there's a lot going on with our gentleman here. Next slide. So we get some baseline labs, right? He's already in the emergency room, which is an excellent place where he really needs to be. And we get some basic labs. And for those of you worried about sepsis, he is a white count now, comes back at 24.6 with the left shift. We got a basic chemistry, which is slightly hyponatremic and hyperkalemic with a creatinine of 1.8 and a lactate of 5. His urine is dirty with positive glucose and nitrates and numerous WBCs. Chest x-ray, large coronaries, but no obvious infiltrates. Because of his altered mental status, he got a head CT and was consistent with significant atrophy, but fortunately no blood, no left shifter mass is attributed. And your colleagues in the ED reaffirmed that they did a bedside ultrasound, which is helpful because you can rule out some really scary things, right? So LV problems, tamponade, effusions, etc. In a patient like this, you would have a low threshold as well to probably image more. A CAT scan wouldn't, I wouldn't fault you for thinking about that, especially if some significant findings on his exam, like his abdominal pain, that it's hard for us to truly assess. Okay, so a lot can happen very quickly with that immediate emergency evaluation. Next slide. So identifying primary problems, hit next. Many of you already thought of sepsis, right? So fever, hypotension, this altered mental status, you really want to think about septic shock. For an older patient coming from a facility, the common sources you think pus, right? Pneumonia, urosepsis, or soft tissue. But you don't want to miss some of the more occult infections, such as the CNS and meningitis or endocarditis, especially in our older adults who may have some hardware, and we just don't know when or where. Next, cursor. The hip fracture, I think many of you also attributed, so left hip fracture, but the fracture also happened 2 days prior, right, unwitnessed. So something else to think about. Should we be worried about a bad embolus, right, a long bone fracture? Next, possible CNS bleed. What can explain his altered mental status? Is it the sepsis? Is it the infection? Are we sure that we didn't miss anything, right? And we'll talk a little bit about that with the age, and for patients with cognitive impairment, you'll start to see some atrophy in the brain tissue, right? There's a lot more space in that skull. So you want to be, cautious in terms of that and at least getting some imaging at baseline. and rule out trauma, right? So a fall is our geriatric trauma, and we'll talk a little bit more about that. So should we be worried about anything else in terms of his neck stiffness? Is it meningitis, or should I be worried about a cervical fracture? Next slide. Or is this all attributed to delirium, right? And this is our medical emergency, which can certainly, the differential is broad. So whether or not there's something going on here, is it just the infection? Is it pain? Is it the fracture? Most cases, it's a little bit of it all that's contributing to this presentation. Next slide. So this is likely a uroseptic nursing home patient. And the pearls here, certainly you want to view the entire patient. While the sources of infection are likely, as I said, pus, pneumonia, skin infection, or urine, think about some of the other more obscure ones: C. diff, an intra-abdominal abscess, necrotizing fasciitis, endocarditis, meningitis, osteomyelitis in particular for individuals who have pretty severe pressure ulcers. The fact that this patient is coming from a facility, you also want to be aware of some multi-drug resistant organisms, especially for those who've been hospitalized prior or been living in the nursing home for a while, and those who have chronic catheterizations. So as you would do with most patients that you're worried, you want to immediately start to pan culture them and immediately start broad spectrum antibiotics. And be aggressive with fluid resuscitation as needed. May give him fluids. You want to address, he had a lactate coming in, which is certainly concerning, that of his sepsis. So in spite of his age and not knowing what his cardiac function is, you do want to hydrate these patients. You may want to engage your colleagues in infectious disease if there is concern about more complicated infection, or certainly if a patient has hardware that we're not aware of. Next slide. So early goal-directed therapy is indicated for older adults, especially those also with good pre-morbid functioning. So just as you're doing with most of your younger patients, you want to resuscitate, be cautious with their ABCs, but do a full exam. Look for the skin lesions, look for ulcers, assess for hardware. Immediate broad spectrum antibiotics, a goal-directed very early antibiotic. This is where the nursing home paperwork is super important, assessing what their goals of care. Where have these conversations been in the past? Does the patient have a DNR, a DNI, a MOLS form? Can you contact their next of kin? And then along working with your critical care colleagues and determining whether or not the patient will benefit from additional fluids, pressors, with aiming for a MAP of at least 65 and transfusing as needed. You may need additional imaging, right? So the older the patient, the greater the risk of the fall, the greater the risk of the fracture. Sometimes the fractures are missed with regular x-rays. So a CT scan, and then think about providing significant analgesia as needed. You may need more information and more collateral from the nursing home, and certainly aligning whatever treatment guidance that you're giving with what their overall goals of care are. Next slide. When you're thinking about fevers and falls and altered mental status, this gentleman had it all. As we saw earlier, fall is the most common presentation to the emergency room for our older adults. It may be a simple trip and fall, but it's often a sentinel event. While this gentleman did have a temperature, you may need a rectal temperature. The fever often indicates that it's more of a bacterial infection rather than viral. However, in an older patient, the lack of fever does not exclude that this could be a septic patient. And again, the older the patient, the more likely they are to fracture. And be wary of antibiotic resistance, especially those who are coming from the nursing home or had frequent hospitalizations. Next slide. Untreated pain can also contribute to his altered mental status. So just some guidance in terms of how to assess pain, okay, and how to treat the pain in an older patient. The mantra in geriatrics is start low and go slow, certainly, but it is safe to give opioids as long as you're dosing them safely. So for this gentleman, options are, well, morphine I probably would have avoided, knowing that his renal impairment, that he had some renal impairment, but hydromorphone could be a good choice at the lowest doses and titrate as needed, especially if there's plan to bring him to the OR, get more imaging, or transfer him to the ICU. If he needs the central line, it should be placed into our ultrasound guidance and maintain precautions. And as I mentioned, don't be afraid to advocate and engage your ICU colleagues. He will need DVT prophylaxis. He also needs orthopedics to fix the hip, but he needs to be medically stable to do so. Next slide. So just a few take homes on geriatric trauma, right? A fall is our geriatric trauma. Nearly 1/3 of our older adults will fall every year, and nearly 60% of nursing home residents actually do endorse a fall. And those who have a fall, nearly 2/3 will fall again, right? And older adults often talk about the fear of falling. Falls are the #1 cause of injurious death, and 25% of these patients who do have a hip fracture often die within 6 months. I know at Morningside you do have a trauma team, but interesting data on trauma activation, especially for geriatric patients. They tend to be activated a lot less for our older adults, nearly 14% for a geriatric population, as compared to 30% for the non-geriatrics, despite the fact that older adults tend to have 4 times greater mortality. Again, I mentioned being aware of these occult fractures, that sometimes an x-ray is just not enough and you have a low threshold to get further CAT scan imaging to truly diagnose these fractures. Typically, the emergency room will be great and the trauma team is great about doing PAM scans on these patients. One thing I want to highlight too is the cervical spine evaluation, right? For traumas. For older adults, they're more likely to have higher, their cervical traumas or cervical injuries higher up at C1, C2, which can lead to significant paraplegia. A little different than younger counterparts who have injury more at the C6 and C7 cervical spine. And just a reminder about caution about head trauma, right? So there's certainly more space in the skull with older patients, such that they may often present with an asymptomatic intracranial hemorrhage. So 1 in 6 are asymptomatic. 15% of these cases are seen with patients on warfarin, or right now we have a lot more of these novel anticoagulants, which also have a high risk of intracranial bleeding. So be mindful of also repeat scans for delayed bleeding that may happen, even with a minor trauma. Next slide. And just a comment here on fevers in older adults, or what we call the geriatric fever. So temperature may be less sensitive amongst our older adults, especially those living in the nursing homes or coming from senior centers. Older adults tend not to localize symptoms on their physical exam, and we'll talk about that more in the next case. And their cognitive impairment may not be able to tell you where they're having pain or discomfort. So the Infectious Disease Society of America, or IDSA, recommends modifying that definition for a fever. So geriatric fever, you can think of as either a single oral temperature of over 100 degrees Fahrenheit, 2 oral repeated temperatures of above 99 degrees, or an increase of temperature 2 degrees Fahrenheit above their baseline. You know, the risk of sepsis is greater for older adults in terms of mortality. And certainly these patients tend to decompensate very quickly. Next slide. When you're assessing patients, and in particular the older adult or the older trauma patient or trauma patient that you're worried about shock, it's important to really recalibrate what your vital sign thresholds are. As I mentioned, they have greater mortality, even though they're often under triaged. So a heart rate of over 90 in a geriatric patient is considered almost equivalent to the heart rate of 130 in a non-geriatric patient. This is in a trauma setting, right? Same as with the systolic blood pressure. Blood pressure in 110 seems okay, but truly that may indicate a blood pressure of less than 95 in a non-geriatric patient. So if you recalibrate what those thresholds look like, and you have an older patient potentially with a blood pressure of 93/68 and a heart rate of 134, that is concerning for shock, be it hemorrhagic shock or septic shock, as we've seen here. And sepsis is common in our older patients, but they're more likely to present atypically, as we described. Only 50% actually mount a fever, as we'd seen in this case. And older adults tend to have a lower baseline temperature, so 97.3 as opposed to the 98.6 that you're typically used to. And risk assessment tools such as the SIRS criteria and the QSOFA have less sensitivity for to pick up sepsis in older adults. And then always be wary that that altered mental status or that failure to thrive may be that only presentation that something is off with these older patients. Next slide. Okay, so I'll pause there for a second. There's a lot of information that I share, but I just wanted to walk you through some of the things to be concerned about with just a simple fall as a presentation, and the things to think about in terms of atypical presentation, what sepsis looks like, and how to assess for an acute trauma. So speaking of falls, this is just a rebreather, which is actually, I love this slide, is there. These patients are on their walkers, but yet still very functional and active in their senior center. We're going to switch gears with the next case, if there are no questions. Next slide. And we're going to take it to abdominal pain. Remember, it's a little less, not as common, but certainly one of the more perplexing diagnoses in an older patient. So I'm going to ask you just to think about this and each one of these statements. And you can probably just put in the chat box whether or not you think the statement is true. So number one, making a specific diagnosis in abdominal pain is more common in young adults than in seniors. True or false? Okay. Abdominal pain occurring before nausea and vomiting is more likely to have a surgical etiology. True. Giving small amounts of parenteral analgesics in the emergency department of patients with severe acute abdominal pain will delay or obscure a diagnosis. Okay, great. Perforation of an ulcer. Oh, sorry. Gallbladder, bowel, or appendix is more common in seniors than young adults. Got some truths there, excellent. And then finally, mortality is higher, especially in the oldest of old. True. Okay, great. Next slide. You guys are really good at this. So yeah, so the ones highlighted here are the ones that are true. So abdominal pain before nausea and vomiting, more likely to have a surgical etiology. Older adults are more likely to present later in terms of these acute infection, cholecystitis, appendicitis, and present with a perforation. And certainly the morbidity and mortality of acute abdominal pain is a lot greater with older adults. So let's quickly, I'm mindful of time, so we'll quickly go through the next case of Mr. LC, who's 85, who presents with 2 days of abdominal pain. He's an active senior, only medical issues, some mild hypertension. He does not have, he drinks alcohol socially, and he's coming in and he's describing his pain has been diffuse and crampy, and he's had 2 loose bowel movements. He denies any fevers or chills or weight loss, no nausea, no vomiting, no chest pain or shortness of breath, no other bowel complaints or surgery. No travel, no sick contacts, no new foods or medications. So really a vague complaint, 85 years old, otherwise a well 85-year-old coming in with not feeling right in his abdomen. Okay. So what are you worried about? What are you thinking? What do you want to do for this gentleman? Let me go to the next slide and give you his exam. So as I mentioned, he's actually a relatively healthy looking 85-year-old, looks younger than his stated age, but he is uncomfortable. He didn't feel febrile, but he has a rectal temperature of 100.4, vitals otherwise 140/80, pulse of 90. He's describing his pain as severe, 8 out of 10. There's no jaundice, no temporal wasting, no stigmata of alcohol use. His lungs are clear. On his abdominal exam, it's slightly descended with normal bowel sounds, no ascites, diffusely tender on the right lower quadrant, but no rebound. Guaiac positive trace and no impaction. Skin exam is unrevealing, And in terms of his lab work, his urine studies are done are negative. His chemistry is within normal. His CBC is concerning for a white count of 17 with 12% bands and a lactate of 3. Okay, what are you guys thinking? What are you worried about? Oh, SBO, okay, great. Mesenteric ischemia, okay, all good, all things in our differential. Let's go into the next slide, okay, so worried about diverticulitis, okay, the differential's there, everything, excellent. Right, so you guys are on it. So the issue with older adults is that abdominal pain is often that vague complaint. A lot of different medications can affect GI motility, just with normal physiological changes. We'll talk about in terms of the exam and lab issues that there's altered perception of symptoms. Older adults may have more functional bowel disease. And as some of you have already mentioned, they're at greater risk for ischemic bowels. Does he have a history of AFib? Are you worried about poor perfusion to the gut and mesenteric ischemia? But because of some of the normal physiological changes, there are often delays in when the patient will present. So even though abdominal pain was there for a couple of days, he may have lingered with it for a bit longer. In terms of some of the exam things I'm worried about, so with aging, you have thinning of the musculature, which makes guarding and rebound less common. You have thinning of the omentum, which may alter the ability to wall off a perforation. Certainly there's decreased blood supply, which can make ischemia and perforation more likely. And for older patients who've had prior surgery, so I know some of you are thinking small bowel obstruction, you know, that they've had altered anatomy based on prior surgeries. And certainly things that we think of atypically, like the delayed response in terms of fevers and white count, though this gentleman did have a white count. Next slide. So the differential, I think many of you got several of the things that we would be concerned about in the top of the list there: diverticulitis, ischemic colitis, an abscess, appendicitis or cholecystitis, or an obstruction. Less likely are the common things: late onset IBD, a volvulus, mesenteric ischemia. He didn't have too many other risk factors for that. Lactose intolerance, so less likely. But this is a gentleman who's coming into the emergency room, so you're really going to focus on that differential there on the left. Next slide. So what are you going to order? What studies do you want? I've listed here a couple of options. What's going to get you the most bang for your buck? An obstructive series, a chest x-ray. We can get that nice and quickly in the emergency room. An ultrasound, depending on, I guess, on what's your differential. I can give you some information for some of those conditions listed. Colonoscopy, unlikely. We're often recommending to have a low threshold to get a CT, right? Because of everything we just mentioned. So 1 in 4, yes. Next slide. Yeah, so you can certainly start with an obstructive series or chest x-ray. It's really useful to see free air or the abnormal bowel gas pattern if you're worried about a small bowel obstruction. You may also find a pneumonia that can be extremely severe, causing, you know, I've seen that with right lower lobe pneumonias causing severe abdominal pain, or calcified AAA. May be insensitive to other issues, but certainly a good start in an immediate test to get some information. Next slide. Here is an example of the obstructive series. So you actually get 2 views. So on the left side there, you can certainly see the dilated loops of bowel. And then on the second image here, with the patient sort of lying on their right lateral D-cube, you can see the various air fluid levels, okay? So certainly worried about an obstruction that we're already seeing. But for those of you who said CAT scan, often now we're recommending that we go straight to CT, because even with this information, you probably want more information. So next slide. Exactly. So don't you go for the CT? Yeah, actually more of the latest evidence. And I think most emergency providers, and I think you, if you're the admitting physician, it's hard, you know, it's hard to argue against getting the CAT scan first. You'll get a lot more information. Certainly you may need surgery to weigh in, and they're going to want some of that objective finding as well. So a lot of a lot of the guidance is going straight to the CT, and here we are. This gentleman did get both. He gets a CT, and I don't know, what do you notice here? Anyone want to take a shot at what they're seeing here at a quick glance? Right, so air fluid level, yes, so you certainly see the air fluid level. It's concerning again that there is this obstruction. I don't know if you notice here, though, this little target sign here, right? That bullseye is where the appendix is with some inflammation around it. Really that thickened ring causing some inflammation that led to severe small bowel obstruction. Next slide. So certainly things to think about, especially with an older patient, and one like this, 85, but otherwise relatively well. Symptoms are often vague. It's often very hard to describe and very hard to localize. But 1 in 2 of our older adults will potentially have a surgical abdomen. So these small bowel obstructions and appendicitis are surgical diagnoses, and they're often missed. You know, you can miss it, and then these patients come back even sicker with a perforation. And while appendicitis is less common in older adults, it still represents up to 7% of the cases, and that retrocecal presentation may often be missed. And as I mentioned, a failure to diagnose increases the risk of a poor outcome, a risk of perforation. So certainly have a lower threshold to order advanced imaging and CTs for these patients. And in fact, we're probably not ordering them enough. Next slide. Typically, as I mentioned, the pain is very difficult to describe. So things that we're used to in terms of identifying right lower quadrant pain and the positive Bernie's point in appendicitis, or the right upper quadrant pain and the positive Murphy signs for cholecystitis. Left lower quadrant pain, we're often thinking about diverticulitis or epigastric pain and pancreatitis. Our older adults will just come in and say they have pain everywhere. And it could mean any of this. It can also mean something like an pneumonia or an MI. So that's why it's very hard to just really focus on what we're learning in the textbook. You have to sort of think outside the box for our patients. The pain is often described as pain all over. And this is certainly due because of the visceral sensation is compromised and physiological changes that we expect. Older adults are 5 to 6 times more likely to require urgent surgery, and really 2 times more likely to die compared to younger patients with same presenting symptoms. So often require more of a workup and more testing. How are we? So I may skip this third presentation because I know we're at the top of the hour. This was one on altered mental status. And I'll tell you when to stop. So just some take home point. Oh, I'm gonna just review the last slide just as some key take home points that I hope will stick with you. One is to be aware of these atypical presentations. I think the first case really outlines some of them. You know, altered mental status, the lack of fever, potentially the lack of white count or the delayed presentation of that leukocytosis. Be vigilant about delirium, right? I didn't name it specifically, but knowing that delirium is our medical emergency for older adults. And while there's a textbook diagnosis for an older patient, it may just be that failure to thrive, that altered mental status, right? That inattention, that they're just not their self. And it requires us as clinicians to do a more broad workup. You certainly want to consider and exclude dangerous diagnoses by age. And I could already tell from you guys as an audience, very interactive, that you are thinking broadly about these diagnoses. Except that our patients may require more time and may need a bigger workup and more testing, but certainly close follow-up because they are also more likely to decompensate quicker, okay? I think for a lot of our older patients, since this is a sentinel event, being in the hospital or new diagnoses, always important, even as the new clinicians taking care of them, to review and document what's important, their goals of care, and respect their autonomy at whatever stages of the illness that you're treating them. Remember to practice preventative medicine for high-risk syndromes like falls, you know. So as I mentioned, it's the most common reason for a patient to come in, most common diagnosis for injurious falls and mortality, but it may be also the only presenting illness, presentation for some of the other medical illnesses. So even after you've treated your patient, you want to assess them, see that they're safe, that we're not giving them medications that can contribute to that fall, that they have the right assistive devices, and that they're getting the therapy. And older adults tend to represent such a heterogeneous population, but however, we should be using evidence-based therapy to really manage our patients and then adjust based on their goals of care and where they fall in terms of their spectrum and frailty and overall prognosis. So I'll stop there and hopefully have time to engage in questions.
Thank you so much, Dr. Sanon, for teaching us about emergencies in the older adult population. I think this is really interesting and very helpful. We do have a couple minutes. If anyone has any questions that you want to post on the chat or just unmute yourselves, I think Dr. Leipzig can allow us a couple minutes for that. Sometimes we're too shy, but thank you again, Dr. Sanon, for sharing with us. That was really, really interesting. I'm sure if we get any more questions by the end of the afternoon, I can just email them.
Yeah, no worries. And thank you all for your patience with my IT difficulties, but I hope you enjoy the rest of your afternoon.
Thank you.
Yeah, and I will just say that I think guys, keep in mind those concepts and key pearls when going through the rest of the lectures, and especially when we get to the afternoon report and talk about a complicated geriatric case, because a lot of these things are very relevant to the case we'll be talking about as well.
I did have a question, if we have a second, regarding MOLST forms. When you have a patient that's like altered, an elderly patient that's altered when they come in, but they have a MOLST form, you know, explaining their wishes, how do you know like what's changed if you can't like get in contact with someone? Like what's the best approach to, like say a MOLST form was filled out a year or two ago, what's the best approach to like respecting a geriatric patient's wishes?
Yeah, that's a great question, Raj. I often feel like every time I'm admitting a patient, and even those that can provide and participate in the conversation, that you're often looking to get some collateral. So it does require some extra legwork. And I know the difficulty, especially if you're the one admitting the patient in the middle of the night or not, you don't have all the information at hand, which is why I was saying if they're coming from a nursing home or facility, typically it would be that nurse or that clinician that has sent the patient in who had just seen them. Hopefully we'll have the most like the firsthand knowledge of what had changed so acutely. But often takes maybe a couple of phone calls to get more collateral, right? And sometimes it's not the daughter who hasn't seen the patient in weeks. It's the, the nursing aide on that unit. The same is true for if you're admitting a patient from home. I say, oh, wow, you admitted the patient and they were there with their home health aide, right? You are going to get a lot of information about their baseline cognitive and functional status with that collateral. The MOLST is certainly just used as that tool, because certainly the whole point with every admission is to revisit it. Are these wishes still the same? And it's not, it's okay. Sometimes it happens that the patient says, oh, I've changed my mind. I do want fluids and a trial of ICU care. A lot has changed. I bring it up because I think we learned a lot with the COVID pandemic where patients were coming in massive volumes, so acutely ill, and we didn't have the time to make some of these decisions. And this was like a learning pro, like, clinicians didn't have the time to realize that these things existed and that would help guide further conversations. But you're right, it does take sometimes that collateral information from who knows the patient the best.
Thank you.
I'm just going to piggyback on that question, if that's okay, Dr. Sanon.
Sure.
So this is a functionally complex population. They're vulnerable patients, and there's a lot that we have to assess when they walk into our emergency department. Are there any tools that you would, advise that we use as we integrate those in our clinical workflow when we're doing admissions in these patients?
Yeah, so I didn't go through the last slide truly, but I know there's been in the last 5 to 10 years, there's been just this overall haul in terms of the way geriatric emergency care is provided. And I'm pretty sure at Morningside too is a level 2 geriatric ED. So with that, what we've been moving is that some of these geriatric baseline assessments are actually should be done as part of their protocol, whether or not you're screening for higher risk older adults in terms of polypharmacy, vision impairment, how many medications they're on. So something called the ISAR score, identification of seniors at risk. Basic screens like a delirium screen, ED nurses are trained to do that, right? Because that's the biggest concern is that they're missing a delirium and discharging a patient who potentially is septic or has a trauma. So those should be implemented at that early evaluation. And certainly, hopefully we'll have time, and I'm sure with the other discussions, how to do some of these rapid evaluations. One I think of that came up very importantly during the COVID pandemic was something called the frailty scale, the clinical frailty scale. Really that quick observation of where your older patient is. Are they frail? Are they robust? And so that you sort of take that pause as we're making clinical decisions. And maybe that decision is, do I admit or discharge? Or do I start antibiotics or do I call the surgeon? Right? So sort of understanding who these patients are really quickly when you have to make rapid decisions. But there's been a lot of work in bringing that into the forefront. So these assessments are done at triage, screening for delirium, and as like a 5th or 6th vital sign, certainly.